I'm happy to be here and to be partnering with Check Your Genes. It's been a real pleasure to work with an organization that feels so passionate about things that we talk with patients about on a daily basis. So we really appreciate them just allowing us to be a part of the exciting things that Check Your Genes is doing. So I thought we'd spend some time today talking about making sure that you feel armed with information. If you're someone who has tested positive for a BRCA mutation, feel armed with information to be able to communicate effectively with your family members. We'll start first by talking about what happens after a BRCA positive test. And some people are working with a genetic counselor through this process, and I hope that the genetic counselor in those situations has given you the resources you need to feel comfortable and armed with this task, talking with family members, and with also moving forward with your own medical management. But others may not be working specifically with a genetic specialist. They may have a very knowledgeable healthcare provider. Others may need to seek out a genetic specialist or other very knowledgeable healthcare provider to help them through this process. So after someone has a positive BRCA 1 or 2 genetic test, it's certainly information. A lot of times people are coming in for the testing because they know that it will impact other adults in their family. But we know for sure that it also has impact on the care for that particular patient in a lot of cases. It may not, but in a lot of cases it may. So some of the things that the individual as well as their as well as their relatives may be interested in learning about are what are the options, for instance, for increased surveillance, for lifestyle changes that may help to modify the risk associated with these gene mutations. Are there options for prevention through surgery or through medication? And so we'll talk a bit about each of these things so that you feel like you have the most up-to-date information about it. Like I said, I think it's preferable. I'm a little bit biased because I am a genetic counselor, but I think it's preferable certainly if you can work with a genetic specialist, a certified or licensed genetic counselor. I think that can help enhance your assessment as well as provide you with great resources for your family. First of all, a certified genetic counselor looks at family histories every day to try to identify the patterns that will help us know whether someone is at increased risk for hereditary breast and ovarian cancer syndrome or BRCA mutations, or whether there's a different hereditary cancer syndrome that may be at play. Or a genetic counselor may also be able to provide an individual with reassurance about a family history if the risk is not high for there being a hereditary cause in the family for the cancers. Certainly a genetic counselor can walk through the unique variations in testing that's available and the up-to-date, as I mentioned, management options for hereditary cancer risk. There are a variety of tests, a variety of methods for doing the testing that can be important. The testing has also been updated over time, so it's important to make sure if someone's had testing that it's the appropriate test in that person or family. Also can discuss the utilization of genetic testing and actual management for the oncology conditions, particularly for that patient, for instance, and how it may impact their care right away. And again, I think genetic counselors are sort of uniquely poised to provide you with information to share with your family and how it may impact the whole family. Key concepts to communication in this setting, certainly I think it's helpful to develop a plan for sharing your results. You feel really prepared before you take this information to your family. You may be the first in your family to be tested and really be tasked with sharing this information with all those who may be at risk. And that may feel like a burden, but we're hoping that after today you feel like you can really use this information to feel empowered to share all this with your family members. So I think it's important to, some people say, well, I'm really not in contact with that relative. We don't get along well. There's been a rift in the family, that kind of thing. And I think we always encourage patients to think about the importance of how life-saving this information could be to people in the family, and that from an ethical perspective, we really encourage patients to share the information with all those who can be impacted. It is important, though, for those who are within a family to respect one another's decisions about when or when not to be tested. Someone may not be as ready for the information as others were in the family. And also to anticipate some potential changes, even temporary or permanent, with regard to the family dynamic. Those who, a negative test is not always a very positive experience for someone in the family. People may have survivor guilt if they're one of some of the people in the family who didn't inherit this risk, as they've watched other people in the family go through the burden of cancer. If they're sort of off the hook with regard to risk, it may cause some feelings of guilt. Also, feelings of guilt of passing this on to family members can be an issue. And then certainly it can just, again, change family relationships. People may start feeling differently. This is not just a medical issue, but it's an emotional issue as well. So what information should you share with your family? Certainly family history information is important. People may be unaware of the breadth or the depth of the cancers that have happened in the family, and you may be the one who's sort of put all that together in working with your healthcare provider or your genetic counselor and really, come up with the family tree and been the first to really make that all cohesive. So, and those who may not be as sort of closely knit or as who maybe weren't around when this information was being shared just may not be as familiar. So it's important to share the accurate family history as well. Certainly the type of testing that you had done and the result that came out of that testing. In some cases, you might be the first to be able to guide them to accurate information about hereditary breast and ovarian cancer syndrome. It's important, again, for you to feel prepared and feel like you have these resources in play. Not that you need to take the place of someone who is in the healthcare field who's knowledgeable about this, but again, if this is brand new information to a family member, you might be uniquely poised for that. Certainly, I think sharing the risk information in the family. So if they haven't had cancer themselves or their parent hasn't had cancer, they may not be aware that can be something that people have but who haven't had cancer, even if maybe they still are at risk. So important to recognize that people just may not put those pieces together if they don't understand the inheritance of this condition. It's important for people to understand that men and women in the family have an equal risk of inheriting the mutations. If your mother has a mutation, even if your father has a mutation, each of their children has a 50-50 risk, no matter whether it came from a man or woman. And men can also pass this along to their daughters as well as their sons. It's just that the cancer risks are significantly different for men and women, and we'll talk a bit about those details in a moment. As we just talked about, women can inherit this condition from their father's side of the family. We've heard numerous stories in the past about women who've gone to their healthcare providers and said, I'm really concerned about my dad's side of the family, and healthcare providers in the past, and hopefully we're working towards greater education about this, but they may have been told in the past that their father's side of the family wasn't as important as their mother's, and that's really not the case, especially with a condition like hereditary breast and ovarian cancer syndrome. And again, sharing resources may help you to be the first to give them some information that may help aid in their decision to test and where to be tested. So BRCA 1 and 2, this picture, just to orient you, is of the chromosomes that are in the cells of our body. And we have 2 copies of each chromosome, one from our mothers and one from our fathers. The BRCA chromosomes sit on chromosome 17 for BRCA1 and chromosome 13 for BRCA2. When an individual has hereditary breast and ovarian cancer syndrome, they have a mutation in 1 copy of either of these genes. It's not common for people to have mutations in both BRCA1 and 2, although that certainly has happened in some families, but that's a bit of a more unique situation, and it's very uncommon for people to have mutations in both copies of a particular gene. For instance, 2 mutations in BRCA1, that's very, very unlikely. So in general, an individual has a mutation in 1 copy of either BRCA1 or BRCA2. So just to get our language on the same page here, we talk about the development of hereditary cancer and how is that different, if it is, from the development of sporadic cancer. And we think a lot in cancer genetics about the difference between non-hereditary and hereditary risk for cancer. We know that the vast majority of breast and ovarian cancers are sporadic, up to about 10%, which is certainly a significant amount of breast and ovarian cancer is hereditary. So if we talk about non-hereditary forms, it's really damage that can happen to the cells over time, and both copies of a particular gene get damaged or sort of knocked out over time, and that's when a cancer can develop in that particular tissue. However, if someone has a hereditary risk for cancer, they're born with a mutation that gets them a step closer to developing cancer in particular tissues because they have that predisposition or that gene mutation in all the cells of their body. And so that's why we tend to see some of these cancers at earlier ages in individuals who have this hereditary risk. It's not always earlier, and again, we'll talk about a bit more detail about that. Certainly they have this predisposition, and that's what differentiates it. So we say, and oftentimes with families, that all cancer is genetic because it's caused by changes in genes, but only some cancers are hereditary, meaning that those changes in the genes are actually inherited from parent to child. So here's just a rundown, just sort of some ranges of numbers of risk that have been put in the literature based on what are the risks associated with having a BRCA1 or 2 mutation. So you may have heard these numbers if you've had testing, if you have a mutation. But the risk for developing breast cancer in individuals who have a BRCA mutation, if they're female, is between 50 and 85% over the lifetime. And about half of those occur before age 50 or around the time of menopause. So about half are premenopausal, about half are postmenopausal. So you can see it's not only the early breast cancers. that are seen with this. And then there's also increased risk for second primary breast cancer. So someone can have two breast cancers, either in the same breast or in the other breast. And that risk, if you have a BRCA mutation, is between 40 and 60% over the lifetime. So some people use that information to decide, for instance, if they have breast cancer, whether or not they might want to have the other breast removed preventatively. And then ovarian cancer risk is anywhere between 10 and 45%. That differs a bit depending on if you have a BRCA1 or BRCA2 mutation in your family. Both have very significant risks for ovarian cancer, but statistically, BRCA1 has a bit higher of a risk than BRCA2. But with either gene having a mutation, there are very significant risks of ovarian cancer compared to baseline, which is only about 1 to 2% over the lifetime. And then there also are other cancer risks that can be associated with BRCA mutation. So male breast cancer is one that's certainly above baseline. Prostate cancer risk, there are some families where we see an increased risk of pancreatic cancer and also melanomas. Those numbers there, RR stands for relative risk if you're looking at the slide. So those are sort of compared to the general population with the relative risk, or how many fold risk there is for developing those particular cancers. So talking about some of the management recommendations, and this may be a review for some of you who've been through this process, but just in case it wasn't applicable to you or in case you're not someone who's been through this process yet, certainly we talk about a few different opportunities for management for this condition. The first is increased surveillance. So for breast cancer surveillance, for instance, we recommend starting this earlier in people who have BRCA mutations. So it depends a bit on the age of diagnosis in the family, but definitely by age 25. We would recommend getting annual mammograms as well as annual breast MRIs. There's not great data about the timing of whether you do those together or separately, but we often recommend doing them every 6 months. We also recommend frequent clinical breast exams, so twice a year by a knowledgeable healthcare provider, as well as self-breast exams on a monthly basis. So, and then with regard to surveillance for ovarian cancer, we're not quite there yet with having a gold standard test for surveillance for screening for ovarian cancer. You may be aware that people who have had ovarian cancer can follow that cancer with using what's called a CA-125 level, and that's a validated test in that setting. But for people who haven't had ovarian cancer, we don't know how useful this test is. There hasn't been data to say that it saves lives yet in combination with a TVUS or a transvaginal ultrasound. So that is an option for women, but we'll also talk about the recommendation that they may choose to pursue surgical risk reduction for their ovaries and fallopian tubes. We'll get to that in a moment. Chemoprevention really is sort of a big word for are there medications that can help us to reduce risk of cancer in these families or in individuals. Tamoxifen is a medication, again, that's been really well studied in the setting of people who've had breast cancer to prevent a recurrence of breast cancer, but it also has been studied well in women who are at increased risk of breast cancer and can help reduce the risk. So that is an option for some BRCA carriers. Also, birth control pills. There's been historical controversy about whether or not that might increase breast cancer risk, although there's some good data to say that in BRCA carriers it likely doesn't increase breast cancer risk all that significantly. And it actually does, taking birth control pills for a significant amount of time actually significantly reduces the risk of getting ovarian cancer. So all of these options have pros and cons and certainly need to be discussed thoroughly and considered thoroughly, but there are options for management. So in terms of surgical intervention, prophylactic mastectomy is a choice that some people choose, either after they've had a breast cancer and they want to remove the other, either the breast that's affected and the other breast, or if someone chooses to do this completely prophylactically before they've developed a breast cancer, that's an option. So having prophylactic mastectomy reduces the risk of breast cancer by about 90%. It removes the vast majority, but certainly not every cell, not all the breast tissue. And there have been some good follow-up studies, about 14 years in follow-up, that say that it significantly reduces the breast cancer risk in women with a family history. But generally what's practiced now is what's called a total simple mastectomy. And also surgical intervention for the ovaries. This is something, again, we don't have great screening for ovarian cancer at this time that's strongly recommended. And so we do recommend that once women are between 35 and 40 and once they're finished having children of their own, that they consider having their ovaries and fallopian tubes removed. It's really a very effective way, up to about a 95% risk reduction for the gynecologic cancers associated with this, which is really ovarian as well as fallopian tube cancers. But there is still a risk, a small risk, about 4 to 5% risk of developing what's called primary peritoneal cancer, even if someone's had their ovaries removed. So again, again, it doesn't take the risk to zero, but there is, a risk, does greatly reduce the risk. The tubes, this is something that if you're having a traditional oophorectomy or removal of the ovaries, they might not remove the fallopian tubes, but it's strongly recommended in this setting if someone has a BRCA mutation because there's some theory that some of the ovarian cancers might actually start in the fallopian tubes. And also, it's really important, about 2% of women who go in thinking they're having a preventative removal of the ovaries or oophorectomy will have what's called an occult or silent cancer at the time of that surgery. So it's important that the pathologists really look closely at that tissue. And again, these are not details that generally a patient needs to be concerned about, but also something you want to make sure that you are advocating for yourself and understanding what's happening at the time of surgery. So if someone is having a prophylactic oophorectomy premenopausally, it actually provides some protection against breast cancer risk. So removing that large source of estrogen greatly reduces, has a significant reduction, about a 53% reduction in breast cancer risk, again, if it's done premenopausally. All right, so moving on with how to share this information. So there's really no right or wrong way to share the information with your family, particularly your test results. You know your family best, and so recommendations can sort of be a guide, but certainly I would recommend doing what makes sense for your particular family members, and that may differ depending on the particular relative. So considering how close you are with a particular relative, what are the family dynamics with that relative, how far away are they from you, and how are you most comfortable communicating with others? How do you feel like you're most comfortable sharing information? And again, I think just preparing yourself, thinking through what information you need to share and how best to convey that information is really the best place to start. So this could be one-on-one, sharing it either over coffee or over dinner or something like that, or it could be in a larger group setting with family members, could be by telephone, could be by email. And certainly if you're uneasy, I would encourage you to talk with your provider who has experience with this, because we are certainly here to help. This is just an example of a letter that you might consider sending to a family member, some text that we thought might be of use, letting them know that you've had testing done, that it's their decision to even find out more about what you've had done, that you might share the results in an enclosed sealed envelope or something like that so that they have the choice. It may be that a lot of your family members know you were going through this process already and maybe be asking you for the results right away, but others, this may be very new information for them, and certainly I think just sort of easing them into the process, allowing them the choice of when they really see all this information might help for them to feel empowered about making decisions going forward.